relevant, irreverent data. Okay, we're recording and off. Off we go here. We'll see what. I know. Voila. Female repro. This is really our last major topic. I'm hopefully if there's overflow on Wednesday, I have a little stuff on like growth and gestation and like development and a little bit of aging. Part I always say that to the end. I don't like to do it. So it's, the anatomy is simple to my mind, comparatively speaking. The physiology is hardly simple. We know about the hormones. We know about the system. So here, the external genitalia is very, very limited in their function. Very much so the internal genitalia is really what it's all about. When we're dealing within the pelvic cavity, the ovaries, the uterine tubes, or there's so many different names, oviducts that you could use. There's like fallopian tubes back in the day, uterus, vagina, etc. So the system is different and a different subset of things that go on because highlighted by the anatomical differences, I think, because here we have systems that are in close proximity but not shared, such as in the male we have obviously the urethra and the means of the ejaculation of the sperm. So urinary exit and ejaculatory exit is shared. Here, we certainly did. This is an exit level. This is an entry level. It's associated with it. We know about them anatomically. The interesting thing is that I did this in anatomy, but it really is more a part of this whole idea of ovarian ligament and broad ligament and what it is, and we'll get back to that in a bit, that are there. That's what, when we talk about something called pelvic inflammatory disease, very significant. We didn't do this yet, did we? Okay, we get to, because we do have some sexually transmitted disease. I do have to cover at the end. Reminded me is that those, when we talk about pelvic inflammatory disease, which is really effectively an untreated or undertreated or problematically treated sexually transmitted disease like gonorrhea, like chlamydia, like trichomonas vaginalis. All of these things lead to such marked inflammation and damage in the effect. The inflammation is such that the whole area is inflamed, and when that occurs, inevitably it means an increased likelihood of ectopic pregnancies, increased likelihood of early onset hysterectomies, increased likelihood of infertility, of sterility, if you will. It's not good. Not good at all. So here, with regard to this is the important part when we do address the whole idea of menstruation. We have the ovarian branch of the uterine arteries. The ovarian arteries or gonadal arteries are separate, one on the right and one on the left. Okay, and then yes, there's a tiny branch off the uterine arteries. The uterine arteries are the big players. They're off the internal iliac, and they're the ones that account, if you remember, because we covered a fair amount of it here, that are responsible for those spiral arteries that lead to menstruation. And again, you might remember that we have a hard fibrous coat, very similar to the testes, surrounded by more of a peritoneum coat, the so-called germinal layer. So the tunica albuginea is that white hard coat that you're trying to demonstrate here. And the biggest single area, other than this broad ligament and suspensory ligaments, all being part of this inflammation system-wide in this really tragic instance of pelvic inflammatory disease, which inevitably, to our way of thinking, always implied significant and damage is going to be effectively irreversible, is the fact that this is a discontinuous system, unlike the male. So when the ovulation occurs, it's ovulated into the abdominal peritoneal cavity. And it has to rely on structures like fimbriae. It has to rely on structures like cilia. It has to rely on mucus threads and little eddies and currents to sweep that in, which it does with very, very rare instances of something along an ectopic pregnancy within the peritoneum, though it can occur. So, that discontinuity, and by the same token, when infection creeps its ugly head up, it's not just going to be confined to the ovaries, that infection is going to get into the abdominal peritoneal cavity and cause peritonitis. And most of those infections are gram negatives. That's going to be immediately life-threatening. I can't tell you how much of this stuff we saw when sexually transmitted diseases were rampant in the what I call the pre-HIV era. It didn't mean that HIV didn't exist, that people were blissfully unaware of it. Blissfully. Okay, physiologically, I don't want to necessarily, to me, it's more anatomical than physiological. We know that one egg ripens per month. Typically, they alternate sides, not always, for ovulation. That what's unique about that primary follicle as it develops, when we can see it when it's effectively ready and it's part of development, we call it an antrum. It has a fluid-filled vesicle that sort of has the egg on one side and the fluid eventually making part of the fluid basically enlarges the enclosure in such a way that it really is almost one of the triggers for ovulation. It's pushing on that ovarian wall. We go back, and remember this part, they kind of go around the horn like this. We do ovarian follicles at various stages of development. And again, when we start to see the fluid, and you'll see better illustrations of that, but all of that occurs in the cortex, the blood supply, lymphatics, nerve supply is all central in the medulla. Pardon me. Rest of the anatomy pretty straightforward. The tubes themselves, the uterus, the vagina. I did send you a recording. It was relatively brief, like about a half an hour. I took it right off the test. You only got, areas I tried to give you. You should all do well with that. Or else. Because I don't want to see you in my classroom again other than as visitors. For the most part. But you'll be taking anatomy. So I may have to see you again. Not in physiology. So fallopian tubes, oviducts, who cares? Okay, where things occur. So the infundibulum is the opening. Again, the fimbriae, the little finger-like, projections that are there, they're ciliated. And then if the ampulla, half the uterine length, and so it's not where the egg enters, and it's not where it gets to the uterus. It's somewhere in between there. It's usually in the first, coming from where it enters the tube, about 1/3 or 1/2 of the way is typically where we see fertilization occur. Obviously, if we see implantation occurs there, now we have an ectopic, or what they call a tubal pregnancy. Okay, stiffen, sweep, carried along, peristaltic motions. Yeah, the ciliated cells are for movement. Anything else is just providing nutrient sources where there are secretions. Covered by peritoneum. Okay, when you see sal pinks, it implies tube. When someone has to have my first wife they injected dye into the area to see if her tubes were patent. If they were, it was called a hysterosalpinogram. I assume there are better ways to do it. She said that was very unpleasant. She had that done. We're talking, 45 years ago. All that happened. So here's the ectopic. In the peritoneal cavity, much less frequently, or the uterine tubes. And this is the problem. If they naturally abort, it's the bleeding is the problem. Someone can easily bleed out. Normally you have to go in and you have to basically effectively address the bleeding, and that tube is no longer functional. So at the very least, one tubal pregnancy reduces the likelihood of fertility by half. The big point I've been making is we're doing this, we did the male unit in my 2 A&P lectures that preceded you, is this, I commented on it before, we have so many problems with infertility, with erectile dysfunction, with falling population. I mean, and it's wide open territory for conspiracy theorists and people depopulating. It could drive you crazy reading that. And none of this is my area of expertise. I've seen all sorts of articles about this. I don't quite understand it myself. I don't recall all that myriad of problems. And to have, even within my close family, biological or non-biological, to have two who wanted to have kids, both having to have IVF is very troubling. Here's the PID part that tracks the peritoneal cavity, this type of infection, scar tissue, and it often does. Uterus, this is the normal position for the uterus, drapes over the bladder, puts pressure on certainly during pregnancy. Retroverted, where it inclines backwards or upward, it's almost, we call it tenting. We see that during the arousal phase of intercourse to facilitate the movement of the sperm. Anatomically, remember, dome shaped like the stomach, you have a fundus, here you have a body. We're really where the implantation usually narrows at an isthmus, which effectively is the inferior outlet. That little area, which is the neck, they call it the cervix, and everything else is pretty straightforward. Those glands in the cervix, that's part of that magical process where that mucus is unblocked by a combination of different things at mid-cycle, both on the female side and by prostaglandins that accompany the ejaculate on the male side. Fascinating. Oh my God. This is the one you do have to know about. I mean, these numbers this is probably 8 years ago. I'm not here to be preachy about it. Uh, a terrible problem, please. I mean, your idea on vaccines and whether they're appropriate at which times, that's a matter for you folks are still in the window where you could have it if you did not. But all of these things, the idea of pap smears, having these things checked, so terribly, terribly important. The preachy point, look, you do what you want to do. You lead your life the way you want to lead it. But if you're having unprotected intercourse, whoever the partners are, doesn't matter whether it's same sex or not same sex, it doesn't matter to me. Leave the dog alone. Joking. I shouldn't be flip about it. But for heaven's sake, get checked frequently. Ah, women are good like that, men are not so good. That's my preachy point for today. Don't care about any of that. Don't care about any of that. Seen that before. Prolapse uterus occurs all the time. Uterine structures, we did really the big players are the endometrium. Remember, because there'll be questions about that again. We have the two strata, the one that's always there, the basalis. You remember the one that develops, increases, and sloughs? That's the functionalis. That's the big player. It's just a giant muscle, smooth muscle, okay, and has an outer layer of peritoneum. That's about it. But that endometrial area is really the critical piece because every cycle, and we get to the menstrual cycle and the ovarian cycle, we have the functionalis. That's the one that responds to those hormones, the part that's shed during menstruation, and it forms from the basalis, which is always there. It doesn't change whatsoever. And here you can see this is when it's highly developed. Here's your smooth muscle. Here, the base layer, which behaves like this. And how do we know it's well developed? We get to measure the thickness. And then once you start to see these glands, which are eventually going to be secreting substances to nourish rather, and the proper term, let's say the embryo when it's implanted. I always get those confused about what, the implanted fertilized egg and whatever those different developmental stages. As I said in my previous two classes, I had embryology in 1973. It's a while ago. Once you get to 55 years, even I forget things. Uterine arteries, internal iliacs, arch over the muscle. They radiate, means they go straight in, and then they spiral. That's the whole ball game. What happens when their supply of progesterone, because progesterone drives the bus to make this up. The part that makes the functionalis is progesterone levels. When they're not there, Those spiral arteries kink, they spasm, blood flow is cut off. When there's no blood flow, it separates those layers, builds up a pressure head behind it. We've talked about this before. And the pressure heads don't last forever. As soon as that, there's a relative change in the progesterone levels and there's some more production, boom, just blows it apart. So voila, there you can see the spiral arteries arching here, radiating here. So the straight arteries basically are confined, okay, serve the basal layer, don't deteriorate, but once the spiral ones adjacent to it, those are the ones. So you can see when you have glandular structures that are well developed. Birth passageways, the vagina, more elastic in nature, it's designed. That's the distinction. The fibroelastic nature is much more forgiving and less likely to be damaged vis-a-vis. It's the problem why anal intercourse had so much of an association, particularly with HIV, because of being the preferred method in the gay male population, and why we didn't see it so much in heterosexual couples. It's anatomical. It's more likely to tear. That fibroelastic makes the vaginal mucosa much less likely to tear. So as you can see, acidic in the adult female, alkaline in adolescents. The protection against disease in adolescence is all about, in pre-adolescence and in postmenopausal, is about mucus. Everything else is lactobacillus. Why lactobacillus? It's in the vaginal area. It's the principal fermenter of glycogen. And why glycogen? Because the estrogen makes the cells in that area profoundly filled with glycogen. And the lactobacilli just have a fermentation party. That's why, but they're very easily killed by antibiotics. The proximity of all of these structures leads a lot. Unfortunately, we're not even talking about incontinence and hygiene aspect of things, but the relationship of all the structures together, and then the problem anatomically vis-a-vis people who trying to do abortions who were either untrained or self-abortions is a nightmare. It's really probably the primary reason why Roe v. Wade was passed back in '74. I wonder. I mean, it was a nightmare what people would do. This, not going to go into it. Homologous, the bulbourethra, just lubrication, the glands and the prepuce, the clitoris, etc., etc. The perineal area saw before, and again, and you can see the relationship here of the glandular structures. You can see all of these things that are there. There's a similarities between the male and the female. Again, mammary glands, what's noteworthy about that, the tail of the mammary gland goes into the axilla. That's how, by the lymphatic structures which carry breast cancer as common as it is, why you have to look at the axillary area. It's mandatory. Whenever they're doing a breast biopsy, they're doing a lymph node biopsy in the axilla. Unless you're very, very fortunate and they do we could call it a frozen section. You take a piece out, tissue, you send it down, it takes 15, 20 minutes in a big hospital. They fast freeze it like a liquid nitrogen, slice it, slice right away and look at it. And if it turns out, if it's non-cancerous, or what my mom had, which was a cancer in situ, meaning it was cancerous but completely confined, and you don't have to do anything. My mom was like, oh, I know. So many of the gals she knew, her age group, were having major surgery. She was just so frightened. She was so diligent about getting tested. It's remarkable, like it was yesterday. Okay, and again, we think it's the anatomy. You don't have to go over, but basically, it's a glandular structure. But the bulk of the mass is fatty in nature, and the glandular structures increase during milk production. So if we look at the non-nursing woman glandular structure, it's relatively speaking undeveloped. It's all about fat deposits. So we don't have to go any farther than that. Here's the breast cancer nugget. Effectively after lung cancer, this is it. Yeah, I think that number is conservative, and relatively low. The numbers that I have seen, again, 1 out of 6, 1 out of 7. It's just awful. Okay, tiny cells within the ductal structure. The risk factors you should be familiar with: early onset and late menopause, no pregnancies or first pregnancy late in life, no or short periods of breastfeeding, family history. And the funny thing is the next slide. 70% of women have no known risk factors. I know you've already gotten chapter and verse on the BRCA1 and 2s that are there. 10% hereditary defects, including mutations of these. The number is so high. Risk of ovarian cancer. I'm sure I told you the same anecdote. My cousin's wife had lost 2 aunts to breast cancer, and then they discovered the same problem with her. She had double mastectomy. Relatively young, I would dare say she already had 5 children, and older now. I mean, she's probably a few years, probably in her 60s now, but she had a lot of when they did she elected to do the reconstruct. A lot of problems. She was borderline anorectic. Lost contact with her. Nice people. All right, and the mammography, I don't know what the criteria are. We're getting there to the physiology, but I wanted to do this review because I'm sure some of it is on there. I don't do that. Hello! We're not doing these. I don't, again, I had it up there on the other question. We've already talked about chiasmata. We've talked about law of independent assortment. I don't have to talk about it again. It's very possible, knowing that the primary oocytes, which women are born with, roughly 450,000 by most estimates, are arrested in prophase 1. And if they resume, because obviously there's a limited number of menstrual cycles, okay, in secondary oocytes, meiosis is arrested in metaphase 2. Those are the ones that are ovulating. Yes, sir.
So you know how a woman takes, like after the age of 40, it increases the chance of
trisomy.
Yeah, trisomy. Does that also apply to if the eggs have been frozen because they're also still frozen in a
where they are in metaphase 2?
If someone decides
I don't. Short answer is I don't know. That freezing the eggs is something. Like I said, you're going to have to research it. I was going to speculate about it. I mean, when my daughter did her egg donations, of which she did many, she was between the ages of 20. I would dare say between maybe 23 and 33. So I don't think she was. Yeah, I mean, it would be more relevant. You know what I'll do? If I could, I'll think about it. I'll text my daughter-in-law. And the reason I would text her, because when they did the egg retrieval, Jill was probably pretty close to 40. I wonder if they mentioned anything to her. I mean, that again, it would be anecdotal. Maybe they said, maybe they didn't. But she was getting, oh, she's a little bit older than my son. So she's, so I guess maybe the risk was higher. Thank goodness. I mean, we're doing pretty good. So remember those 2 numbers, prophase 1 and metaphase 2. The follicle, the functional unit that encloses the oocyte, because that follicle is going to turn into eventually the corpus luteum. Okay, and there's a lot of development. So we start with the ovarian follicle. Okay, primordial follicle, a single layer of pregranular cells surrounding the primary oocyte. That's the follicle. And so you're going to see it goes through a variety of stages. So we have the development of the follicle till we get the secondary follicle, and we have the development of the oocytes themselves that are there. So when we get there, when the whatever follicle is selected, okay, eventually when it has developed and it's ready to be ovulated, we call it an antral or vesicular follicle. It's got a vesicle of fluid, they call it antrum. Okay. And so that right before ovulation, that's when it restarts from prophase one and gets going to the next stage. So as you go back and look at that, once again, it goes from prophase one all the way to metaphase two, and it is only completed if fertilization occurs. So you should remember those particular things. Knowing about the vesicle is important, and when it resumes meiosis, it becomes the secondary oocyte. So they show you all of these factors that are here. Here you can see the ovulation portion of it. And then, as you can see here, when the resumption, once it's ovulated, we get the resumption. You get that first polar body, which is, again, you're only going to get one functional egg out of that optimally. So once the penetration of sperm, that completes the cycle. And now we have the ovum, which is fertilized, and then it completes with that second polar body. What happens to the follicle itself? It becomes this, the corpus luteum. The luteum comes from the yellow color that's associated with it. That takes over secreting estrogen and progesterone, mostly progesterone at first, for the first almost exactly 10 days, and will continue to do so if there has been implantation. In the absence of implantation, it will deteriorate and become what's called the corpus albicans, or scar body. And at that point, that because of that will be the sudden drop in progesterone that will cause the spiral arteries, and basically that will trigger menstruation and effectively end the cycle. So we start again. As you can see, during fetal period, prophase one once again, apoptosis. Vast majority, a lot of extras are there, 99.9%. Select few, not necessarily one, okay? High hormonal levels play a role in FSH. One becomes the, quote, dominant follicle. That's there. That was a term I was trying to remember from before, okay? These are polar bodies. The difference here is, and again, you all, I'm sure know, I mean, all of the cytoplasmic structures are from the mom. That's when we do mitochondrial DNA studies. We're only getting half the family picture, we're getting the mom's side. So all the organelles from that. So it's a large cell cytoplasm for that journey, because from the point of fertilization, it takes approximately a week to get to the uterus. The end of that, what we're seeing those for. Typically one viable haploid ovum, okay, where spermatogenesis obviously is 4, but it's different. I don't see why they put that in. I mean, the sperm are continuous. This is a monthly event, okay. Obviously, spermatogenesis begins puberty to old age. This ends in menopause. I don't care about the error rates or things like that. So maturation, there's different phases. I'm not worried about the antral or pre-antral phases. This just occurs. Okay, gonadotropin independent. And these are paracrines that take care of it. But the antral phase, FSH and LH play a role. That selects the dominant follicle and things move on from there. So effectively, you can see there's an amount of time that's there. Okay. And since the oocyte secretes these glycoproteins, they form the zona pellucida that basically protects the oocyte. And that's something I would remember as well. That's, so here you can see the zona pellucida surrounds it. This is the antrum, this fluid that's going to be able to push on a progressively weakening wall of the ovary and facilitate ovulation. I mean, we're starting back here. Okay. Here's the corpus luteum, then here's the corpus albicans. Here, primordial follicle, one primary follicle is selected, the zone forms around it, the antrum forms a so-called vesicular follicle, now a secondary oocyte, finally making its way and being evaded. Here, and here's the remnants of the follicle becoming a functional corpus luteum. So that's all part of it as well. I'm not getting into the thecal cells, the antral phase. Again, I don't think we need to be ready to be ovulating. You're getting to such detail that's more embryo than it is just to me standard A and P. I mean, if any of you are going into fields where you're focusing on this, gynecological or obstetrical fields, believe me, you'll learn more about this than anything I could share with you. This is the cycles. I'm not going to I'll get through some of it, and we'll finish it up easily enough, kind of about what I planned. The ovarian cycle, by definition, is a monthly cycle. It's the one that has a little bit of variability. Ovulation is the midpoint. The follicular phase, where the follicle grows into that vesicular follicle, typically 1 to 14 days. That's potentially variable. As you can see, a limited number of women have statistically this kind of set. Some are clockwork, some are not. It's things that you are aware of or will certainly find out for many of you, depending on your relationships. For guys or women already know about this. And then after ovulation, you have the luteal phase, because it's governed by, look, here's follicular development, here's the luteal phase. When you see test questions, a lot of them are phrased in the ovarian cycle or compared to the menstrual cycle. Which cycle it is immediately tells you what I'm starting to look for. And this is consistent to test it. The follicular phase varies. The luteal phase is always 14 days. It's there. So the follicular phase, the dominant follicle is selected, varies just, governed by FSH, really facilitates that. All the other non-dominant follicles will go away. Do the same thing. What happens once it develops, the process of ovulation, initially the controls are both in the follicular phase are primarily estrogen with some progesterone. What happens here at ovulation famously is called the luteal surge. Okay, there's a large surge of luteinizing hormone. That's the thing that effectively facilitates the rupture of the wall in ovulation. So the German Mittelschmerz is the way it is. This pain that's something that's not consistent. 1 to 2% release more than one secondary oocyte, which will be fraternal twins. Again, the difference between identical twins from fertilization of one, separation of daughter cells would be identical twins. And I mean, there's some irregular parts of it. Depends. I mean, it's the type of thing. Again, my context of infertility. We did what was called basal body temperatures. My wife would take her temperature first thing in the morning. She woke before she was still in bed and plot them out. You had we didn't have digital thermometers. You had basically the old analog style thermometer with the mercury or whatever was in there, the color, and you'd measure. Is it 98.2? Is it 98.1? Is it 98.2? Whatever, and you plot that out. And when it spiked, okay, that was usually the luteal surge. That was the time to try. So that was a standard approach, basal body temperatures that were done. And just interesting about all of those things. Again, if you're thinking, anybody who's contemplating IVF, or any of those methods require a substantial amount of powerful chemicals. Most of those in the estrogen and progesterone-like substance categories. They are designed, okay, to get for multiple births. Okay, they're trying to. If you're doing egg harvesting, you're using the same things. You're harvesting the eggs. You don't get one. You want to get 20. Okay, and then fertilize them in vitro, see which ones are viable, freeze them, like we were talking about, that type of stuff. Here's what they told us: if there's twins or multiple births in your family, and you have to go through IVF, the likelihood of you having multiple births is dramatically increased. Think of the Octomom, who now she had 8, and now they're all grown up. I think they're teens or later. Every time you see a picture, just look it up. And I mean, my dad's brother and sister were fraternal twins. His grandfather was one of triplets. So who knows? Could have really had annoyance. And a friend of my son's, one of his first commanding officers, one of his early commanding officers, they had no history, had quads. They had a child, then they had four more. Four more. Unbelievable. And so what happens after ovulation, the follicle deteriorates. That part will basically, that yuck stuff will be absorbed, but the granulosa cells and those thecal cells, you just have to remember corpus luteum, that secretes, and now it's mostly progesterone and then estrogen. Pre-ovulation, mostly estrogen and then progesterone. Okay, 10 days, this is the whole timing of it. Without implantation, it deteriorates. In implantation, it will eventually stay productive until such time as the placenta forms and it takes over that role. So that so-called luteolytic or ischemic phase, 2 to 3 days, when the endometrium begins to erode, like I said, if pregnancy occurs, then it will sustain it for roughly about 3 months until the placenta takes over. It'll cover the first trimester. So that's where we get to that 14 days, that consistency of the cycle that's there. And so this is less. So once the cycle is established, okay, and this is the interesting part that goes along with it, small amounts of estrogen inhibiting doesn't take much. And then what happens is magically at puberty, as long as there's enough fat, and that's the key issue. That's how many times have I told you about those anecdotes about the figure skater, right? Daughter figures that whole deal. Okay. I mean, they do the same thing with gymnasts. They do with anything where we're teeny tiny cells and trying to prevent that type of thing. I think it's awful, but nevertheless, assuming that the 5 to 15% is there, okay, which is the appropriate level to be in for fatty levels to make sufficient amount of leptin, then all of a sudden, magically, the hypothalamus is less sensitive, the GnRH, the pulsatile nature of it, to finally establish the pattern. Okay, and once that pattern is achieved, after X amount of time, we have the start of menstruation. And so eventually, high levels of estrogen, negative feedback, they inhibit the FSH, LH. Inhibin in the female comes from the granulosa cells, also plays a role, add from the male, it's with from amount of sperm, produce a certain amount of inhibin as well. That's there. And only the dominant follicle can withstand that dip. Okay, and that's why it deteriorates other than the others. Okay. Estrogen levels rise as a result of the continued release by the dominant follicle. Okay, and then interestingly enough, there's a positive feedback. So without going into why, this is another one of those female reproduction where we see positive feedback occurring. That the dominant follicle causes, rather than having estrogen, and now it will make less estrogen based on feedback, it makes more, so it reaches a specific value and it triggers that luteal surge. Can't explain it any other than that. That high estrogen level trigger the stored luteinizing hormone and some FSH, triggers ovulation, completes meiosis 1, secondary oocyte, and just meiosis 2, all the way to metaphase 2. The luteinizing hormone does other local vascular, this is vascular permeability, inflammatory responses, blood flow to the protruding portion of the wall, and effectively all of these events occur to facilitate ovulation. And so shortly after ovulation, the estrogen levels go down. The luteinizing hormone facilitates the corpus luteum, another way that it gets its name. So the hormone stimulates it to secrete. Now it's mostly progesterone and some estrogen right away. The other thing it secretes as well, are you having a question or you're looking at yourself?
No,
I was thumb looking. The other thing it begins to secrete shortly after that is HCG, human chorionic gonadotropin, the substance that produced relatively quickly, and is this, and basically the basis, repeating myself, is the basis of the early pregnancy test, which is very, very accurate. Don't go there. and progesterone with the functionalis. Negative feedback from the rising plasma progesterone estrogen levels then basically feeds back. Inhibin from the corpus luteum enhances that effect. So and then all of these things, declining this. What that means is the combination of inhibin and the plasma progesterone and estrogen levels effectively tell gonadotropin release and FSH and OSH, we don't need you right now. And they particularly, and I don't know what the science is today for birth control pills, but in the early days, it was combinations of estrogen and progesterone. I have no idea what it is. In so many ways, they've been tinkered with. I do not know if there's still a lot of problems vis-a-vis blood clots. That was one of the issues that was associated with it. There were some relationships with certain kinds of cancers. I mean, I would have to go back and look, and I don't know how that has changed today, but I probably should be more familiar with it. And then, of course, it deteriorates, sharp decrease, ends the blockage of SH and LH, and we start all over again. So that activation is about a year prior to ovulation, but it only takes 14 days. So the selection process goes a lot longer. Things like that. It doesn't pay to start this. First thing we'll do Wednesday is we're going to finish this cycle. And really the whole ball game, everybody, is right here. That. One slide does it all. That's right. For your one slide does it all. Okay. So it shows you what's developing in the strata, and the development of the uterine bed for implantation. It's showing you estrogen and progesterone levels. You can look at some of this. You can see the luteal surge here. You can see the spike in estrogen preceding the luteal surge if you draw the lines up, and you can see the events. So this is the menstrual cycle and the ovarian cycle. That's the ball game. Very good. Happy dance. See those that are here Wednesday.